So thanks so much for everyone coming. Our project has been a year in the making, really, and I think we probably want to start off by saying thanks so much to Romy and George and X for supporting us. So what we hope to share with you today is an update from our project, and
Yeah.
Take mine off.
So what we're going to do today is to give you a bit of an update on our project. We've been working on it for just under a year now.
Yeah.
So I'm Shane Webber, I'm the Service Manager for Kent Learning Disability Services.
And hi, I'm Megan Hare. I'm the Project Associate and Co-Lead on the project.
And I know we've got a lot of familiar faces here today, so thanks again so much for coming. So we started the project off at the very beginning with 3 very simple, very key objectives. So we set out to validate the Health Equalities Framework by measuring it against other outcome tools. That was the first one. Second thing we wanted to do was to better understand the current and future needs of people with a learning disability in Kent. And the last one was to further develop our class-leading workforce. And we wanted to do that by really beginning to identify some core skills and future clinical objectives with our Alliance Commissioners, and also to really pull together a training platform that's achievable over the next couple of years. So there were our 3 very, very straightforward objectives. Which has been great, really, isn't it?
Yeah.
Okay. So let's start off with giving an update on our first objective. So we set out to validate the Health Equalities Framework, and we looked at different ways of doing this. We contacted the creators who were here last year and spent a lot of time with them to look at how we can validate this tool, because it's been such a key part of the work that we've done down in Kent. So I think, Megan, you're going to give us a bit of an update on how that's gone.
Yeah. So we're not quite at the stage of finalising our results at the moment, but probably the first thing to find out is who knows what the HEF is. Has anyone used or completed one before?
We've got people in Kent who use the HEF every day who are saying no. Gary, can you give us a bit of an overview from a nursing perspective around how you find the HEF?
I think it's quite, I find it a little bit complex and not really user-friendly for service users.
Okay.
I know it's you can't use a person-centred approach as such, really. I feel sometimes it's a complicated tool. And then seeing that, I don't know, just it's not quite good there for service users.
Sure. And Tracy, how have you found using it?
When we did the programme with you, all of us, as Felicia says, we actually don't get the opportunity to use the HEF with, as Charis said, our service users. So we did validate it against the lifestyle, which was very person-centred. However, we do find, if once you're care planning, I mean, we feel the HEF in at the beginning of intervention and midpoint several times. I've known a person who's open like caseload and at the end. And actually, when you think, I'm right, stuck in all this, where am I going to go? If you actually then plot your HEF again, you can see that your interventions made a difference, or where you may need to work on it, and you can use them in supervision as well. So with regards to a tool where our work is very holistic and we're tapping into lots of different skills and made different interventions, which sometimes you think this is taking me forever, can actually go back and it kind of validates you as practitioners as well as with people we're working with. So there's good things about it, and it doesn't take a huge amount of time, which we're doing with everyone.
Sarah, you also said that you've used the HEF. What's your experience of it?
As a community nurse, a few years back, our whole team used it as a kind of a pre and post intervention, holistic, similar to the colleague as an evaluation tool. We found it quite straightforward to use because it then creates like a spider, like a web diagram, and we use that information to, rather than just focus on what the actual referral was for, was to provide a care plan that was really person-centred and addressed areas that perhaps even to improve their overall quality of life, and then we measured it. So the domains were very clear, and it helped inform the joint planning of the care plan. So we liked it.
I think the good thing is if you can work alongside though, as we work with the Mental Health Trust and social services, it's purely just their health use at the moment, whereas I think it would be good, as Ms. Lady said, it's more of a council approach.
Definitely so.
It looks like a wider determinants of health, doesn't it? So
It
focus
does,
on the
yeah.
social side or other aspects of an individual's life.
So thanks for doing that. So that's brilliant, and that really summarises why we're using the HEF, I think, down in Kent, and why we wanted to validate it. It's gone through some testing before, but it hadn't gone through any rigorous validation. So really, up there is what the HEF does. We've talked about just now some of the benefits, that it can profile someone today, and then tomorrow we can see the key areas where we can target interventions to help people. It can inform clinical practice. We've toyed a little bit around the third point around how we're collecting data, what it means, how we can target services to support people who are facing inequalities, particularly in Kent where we've got the quite a high area of extra support that's needed. And also we've tried to use it to inform some of our new public health strategy as well. So it's been a really fascinating year, I think, for us on the first objective. So just to finalise and summarise really our update, the good news is, from our research, by using it alongside other outcome tools that have been validated already, we can validate the HEF. It's running through the very, very final stages at the moment through our expert reference group, which is made up of a number of key external experts which are running through the cases. There have been some areas that we've discussed and picked up where it's raised some questions, but I think we've worked through those now, and then we published in our final report. It's hard really not to talk about the final report, I think, at this stage. And what we're also going to do is offer some recommendations on how we feel the HEF can be improved. So I think as one of the things that you both pointed out was around how it can be used with people with a learning disability, because it's a bit clunky, isn't it? It's not very user-friendly, and it's a bit dry. So there's some of the other recommendations. Was there anything else that you wanted to?
Some of the other recommendations are around the length of time it takes to complete. Because it's too long to fill in with somebody with a learning disability, it needs to be more condensed so that it can be done in 1 or 2 sessions rather than taking a long period of time just to fill in a form.
Break it down.
Yeah.
Easy to understand it.
Easy to manage and easy to understand.
Because a lot of it's not out there in the community anyway, or even in hospitals you can't find it easily. But even though we've got our communication book, but it could just because I do trust work, I'm a doctor, so I'm one of your experts. Learning disabled adults. Me, when I make mistakes, when we do it for our area, Kent area.
Excellent.
So that's our work around the HEF really, and as I say, our report's going to come out in probably about 6 weeks.
Fingers crossed.
Yeah, so that will detail everything, how we got about it, our method and approach. But really that's a very quick snapshot on the work we've been doing over the last year.
Could you let me know where can we get the report?
Yeah, it's going to be made freely available on our website, as well as anywhere you want to publish it, because that was one of the things that Shane and Megan signed up to, that all the findings are freely available for everyone to look at. So we want to try and stop the working in silos. So I can give you the link to the website after.
And some of the other things, so when we sit down and have our final meeting, that we're going to work through as well is how we can work with the creators of the HEF around some of those recommendations as well, because there's no point of us going off and developing the HEF now. We really need to do it as a wider approach. And probably just lastly to say, we went up to Scotland to do a HEF event with their lead called Heather and they're really trying to push out the HEF in Scotland, as well as Wales, so they had a representative from Wales there. And what we're going to try and do as some of that added value is to get together those leads with us to make some of those recommendations. So quite exciting times, I think. Right, shall we move on to our second piece of work? So alongside this, as if we wasn't busy already, we wanted to try and better understand the current and future needs of people with a learning disability in Kent. And this is particularly important for us because we're seeing such a dramatic change in the needs, presentations of people with a learning disability accessing our services. We've got people living longer, having more complex needs, needing further support. As well as our services, we've seen a huge change in requests for providing reasonable adjustments training to mainstream services. So there's been a big shift over the last couple of years in why and how people are accessing our services. So we wanted to do a piece of work to try and capture that and do some promotion to understand, okay, well, what's going to come over the next few years? And this won't just apply for people and services in Kent. That model can be taken, I think, anywhere around Kent, Surrey, Sussex. So we wanted to keep quite an open approach to this. So Megan's going to talk us through how we did this. So we started off by doing something called a data intelligence review.
So a data intelligence review is an analysis of current data that we have to try and predict what the future needs of people with a learning disability may be by looking at past trends, the current data, and if we can predict any changes because of what's going on in the mainstream population. So with dementia, we know this is potentially going to be an issue for people with a learning disability going forwards because of the trend in the generic population. So we take that information and then we analyse it to see what we think might happen and how we need to design our service around the needs of people with a learning disability, rather than having a service that we provide what we can but isn't reaching the needs.
Excuse me?
Yeah.
My mum's 76. She's in a nursing home in Margate called St Michael. There's one nurse called Sue. She's a lovely nurse because she used to work with learning disabled people anyway. But at home hasn't been taught how to work with learning disabled old people.
Okay.
And I've told the manager there, and I think they're a bit, oh, we don't do that sort of thing. I said, it's about time you do then.
And they're definitely going to need to in the future.
Because you need to, either you lot need to approach that nursing home, because it's a private nursing home yet again. And they don't know nothing about learning disabled adults. That's disgusting, personally, and my mum's one of them.
Maybe we can pick it up afterwards.
And I'm fuming. I am fuming with the
An
whole
interesting
lot.
conversation.
I'm very fuming with them.
Should we speak about it afterwards?
Yeah.
I think that's
We might have some work to
Mm.
do.
Yeah.
Brilliant.
And
Okay.
the doctors have got a load of rubbish and all. Soon top two. Yeah, I'll put a formal complaint into the office.
Good. Are you happy to move on to what are the benefits?
Oh, carry on.
Right, so we talked a little bit around what a data intelligence review is. It's fairly dry for our backroom office, really. It is looking through data, but it's around translating that data to make it real. And that's the skill that Megan's got, and that's really unique. So the benefits are around supporting evidence to improve our services, and that's essentially what all of this is about. It's about using that information to improve the services that we are currently offering. Okay. So our update, our findings so far.
So we analysed just over 1,000 cases, of which we ended up with 975 because some people unfortunately had passed away, or they'd refused treatment, or they'd moved out of area. So we had 975 cases whereby we wanted to track their journey throughout the learning disability service, from the initial referral, where it came from, who it was referral to, who it was referred by, up until the end of what treatment was provided to them and what onwards referrals were made after they'd been closed from the community learning disability team. So there were 4 different types of data that were used for this, which was electronic records, paper records, staff interviews, and the 4th one that I can't remember. The HEF, that's it. So we've taken all that data and we've collated it all, and some of the top things that we've found from it have been that the top 3 referral reasons are for behaviour and emotion, for eating and drinking, and health screening, advice and support. So we now know that the majority of people that come into our service are looking for that type of intervention. So we're now going to hopefully plan our workforce to meet those needs. And then also with the data, what we've been able to do with it is break it down by CCG area so that we can focus the service we provide to the local area and what their needs are. Rather than just providing a generic Kent-wide service, we're able to pinpoint what the needs are in that area.
And this is a particularly important model, I think, because when you're talking about trust getting bigger and working over larger parts of the country, it's really important, I think, that when a trust organisation wants to take that central view, that centralised view, of course they're going to want to do that. But using this model, we can really begin to tailor services to specific areas, because in Kent they just are so very different. So.
Can I just was, I know that it's challenging to get with learning disability research, always ethics and consent is a problem. That's why we have domain. How did you get the consent issues from getting all those data?
Because it's data that we already had, so it was kept on personal records. There wasn't any data collected specifically for this project, so it was already held in the client files and in their patient notes.
Okay, but you didn't need, because it's client's data information, you didn't need client's consent or Charis?
No.
Okay, great.
So do you work with local authorities, because they usually do help community assessment needs? Do you work along with them?
Absolutely, yeah. So we have public health, so we work closely with Multi, who's the learning disability lead in Kent, and they do a needs analysis every 3 years. Now that's really interesting, and what we try to do with public health as part of the added value is for our information, for our data, to be brought into their next needs analysis and to really support some of those recommendations, because they've got their data before from GP data sets, from local authority databases, but by us doing this, it really enriches and empowers that health element of the data. And they've been brilliant on top of healthcare, they're just fantastic. And we've been able to influence the CCGs and things like that. So the added value to this has far outweighed what we expected it to. And considering we're talking about data, which is a little bit dry, it really has seemed to have got CCG's interest and public health interest.
Just on the note, just while because I forget.
Yeah, sure.
All this data is informing statuses in terms of types of services that you ought to provide in the future. But are you going to share this with private providers? Because I'm aware. I mean, I work for a sort of charitable provider. We employ nurses for that purpose, because we recognise that there's a growing need. And it might help inform other providers about what perhaps they need to be looking for in the market for future workforce.
It's shared information. Obviously, there's a competitive market out there, but I don't see the value in just having this shouted on the one. This is about making services better. So I think as Rona, you said, this is around published information. That's part of our agreement from the beginning. So definitely, all part of it. So, yeah, absolutely. Okay, so that's our update on our second objective. And just to keep us even busier, we've got our third aim. So our third objective, which is a biggie. So we wanted to further develop our class-leading workforce, and that's really by taking a snapshot of all of the work that we've currently done building it into a platform to say, okay, what are we really skilled, what are we really good at, what is our experience in, what's the predictions for the future, and what's that gap in between, and how are we going to bridge that gap?
So for this we did a training skills analysis with all our staff members. So they had, I think it was about 22 questions that they answered for us, and we asked all of our staff to do it, and we got an 85% return rate, which was about 110 people completed the survey. And as part of that, they identified themselves what skills they thought they had, what skill gaps that they thought they had, what they thought the change in demand might be, and any skills that they might need in the future to meet that. As well as just information about their working history, how long they'd worked with people with learning disabilities. Because we know that a lot of people are going to be retiring in the next 5 years, we wanted to identify how much skill knowledge we would be losing during that period of time. So through this we've identified that, and now we have broken down a profession matrix of because we have nurses, OTs, physiotherapists, sensory assistants and speech and language therapists. We've made a specific training platform for them to complete, which identifies what they need to do to meet the needs of people with learning disabilities, because we've also cross-referenced it to our data intelligence project as well.
And the other part of the work that we've done, which has been great, and certainly from a nursing point of view, is to look at how the syllabus from universities have really changed over the last few years, and begin to plug that gap. I think epilepsy was one of the things that's no longer covered.
And positive behaviour support.
Yeah, so we've looked at putting that in terms of part of a local induction within our services. And again, that's the same for everywhere, so that information that we share. I don't know whether our team had anything they wanted to add around.
No, we had that circulated to us recently, Penny circulated to us, and I was really impressed. It was really, we felt like we'd been heard, to be fair, and some of it was really good. Yeah.
We'll pay you later.
We can share our own things that we've actually, a lot of us going out and seeking our own opportunities that you possibly wouldn't have been aware of. So,
yeah.
And it's about how we can, within a team we have continuing professional development every 3 months, and we're starting to share our skills that we've learned with our other colleagues as well, and with our HCAs as well. So I think it's encouraging the nurses to share good practice as well. And training, so yeah, it's good.
Can I make a specific question? Because I'm a market care lead in Surrey Borders, and I'm currently finishing a public health degree. And is it market care included as a gap for training in the future? Because in our trust, I've been serving our staff, and so far 98% feel that is essential. However, courses are not provided, that's why I'm there for.
Okay.
And my colleague is the same, but she's in Kent, isn't it?
Yeah, Kent Dartford.
But we feel that, especially in speech and language therapists, nurses, there's a really big gap within market care.
Yeah, it's interesting you mentioned about eating and drinking, because one of the reasons why someone won't eat and drink is if they've got a painful mouth, they will refuse to eat and drink. So I was actually going to ask, is that linking into mouth care possibly?
It is, yeah. So just to give you a little bit of background really about how our work with oral care happens in Kent. So we've got links in with dental practices, speech and language therapists. We've got a couple of, I think we would probably call them expert champions, wouldn't we? Who do awareness type of training. But what we are seeing is that because it's linked to so many other things, pain, that I think it's something that speech and language. Let me just do
We did
something.
mental health group, didn't we?
Yeah.
We did, yeah.
What I think what's happening, especially with mental health and learning disability society, is that because there's no prevention treatment, there's no regular checkup,
Promotion.
there's anything, so I think the treatment available ends to be extractions and general anesthetic, which is a shame, because it could be prevented if we know how to do it years ago.
Valley who actually take it upon ourselves to actually, I'm adults mainly, I'm not learning disabilities, but because my background is from special care dentistry, I took it upon myself to link in with my learning disability nurse at Hare Valley, and together we've actually done a project where any patient who's flagged with a learning disability admitted into A&E, I will go and see, do a mouth care assessment, I will then support the staff in regards to helping with mouth care. I will then obviously chat to the family, make the necessary referrals to the community dental team as well, who have got links with. So we've actually taken it upon ourselves to actually do that learning disability link. But there is a gap with mouth care because I know I chatted to a patient and she said to me, my son's not seen the dentist since he was 7 because he had a tooth out. He's never been. And because we're scared to take him, and she didn't realise actually there was a community dental service that's specially trained to see people with learning disabilities or mental health.
And they'll come and visit you in your own home.
We do that within our teams as well, though, because we have like desensitisation programs that us ourselves run. So we do desensitisation work about teeth cleaning, and we've had like health promotion groups as well, which talk about
Can we capture it afterwards? Because I wonder whether or not it's something that we have captured, but maybe there hasn't been enough. We could do it.
Yeah, definitely.
Let's do that. Is that all right? So we can swap details afterwards. Is that all right? Fabulous.
Can I just say something about your comment about epilepsy and learning disability nursing?
Sure.
Because I'm from Houston University and we do teach learning disability nurses epilepsy. It's part of the curriculum. So I didn't want people to treat something.
No, I think,
It is there.
Yeah, sure. I think it's something that we brought up with our consultant nurse who had said around Greenwich actually. Interesting.
yeah, we do cover it, but I think what it is not all of the HCAs aren't receiving that training, and now there is some, we could do a refresher training, because as we know everything changes. I think some of our nurses qualified some years ago, so refresher training.
Okay, great. So just to round it off then really, so we talked a little bit around our update, our audit, part of that analysis that's going to be published as well. And again, it's the same model that can be shared within Kent, Surrey and Sussex. So it doesn't just have to stay to Kent. But again, all of our information will be shared and published as well. So I just wanted to recap really that they were our three main objectives or three main aims. And again, just to thank HEX for their support and continued support around making this happen, because it is around improving services for people. So that's it. Thanks so much. Do you have any questions? I won't run away, don't I?